So we have a patient who has Gleason 6 prostate cancer, and they've had 46 rounds of radiation. Their PSA has kind of hovered between 3 and 4, but it hasn't gone down. And they're kind of wondering, should it go down? I mean, is there some sort of PSA bump when it comes to radiation, or what should have been the expectation?
Gleason 6 is, as we've talked about before, our low-grade process. We don't worry about them spreading. Prognosis for treatment, if you undergo treatment, obviously is excellent because it's a type of prostate cancer that you can often watch rather than treat. So that gives you courage if the PSA seems to be misbehaving, that the underlying process is not truly dangerous. And we do know that radiation can sometimes cause erratic PSA tests for up to 2, even 3 years after treatment. This phenomena you mentioned already is called the PSA bump, and it is believed to be due to radiation inflammation or radiation prostatitis, and it's unpredictable. It doesn't happen as frequently with the beam radiation that you described, the 46 treatments. It's more common with the seed implant radiation or the short course SBRT radiation where they get 5 treatments over a 10-day period. But it does happen with IMRT and with proton therapy, perhaps in 5-10% of patients. So at this point, with the information we have, I wouldn't be concerned at all. I think it's just going to take some patience. The resolution of this question is, of course, was there a higher grade cancer that was missed on the random biopsy, which can happen. And in the background, there's actually a bad cancer that's misbehaving. And we can resolve those questions now with these new PSMA PET scans, which are now commercially available. Medicare is covering them. We're seeing, unfortunately, some foot dragging on the privates and the HMOs and those sorts of things. And the cost of buying one, I think, is somewhere in the $3,000 to $5,000 range. So they're not cheap. But it can be money well spent if people suspect for some reason that there really is a cancer process ongoing in the background and they want to double check. So you can get a PSMA PET scan. On this person, with the information we have, it sounds like patience is reasonable, and with time that the PSA will probably settle down on its own. When would we get a PSMA PET scan? I suppose if the PSA was steadily rising in an unremitting fashion. People that have inflammatory bumps, you usually see sort of a zigzag. If you graph the PSA out over time, you'll see the PSA go up and come back down and up and down. Whereas with cancers, there's a steady, unremitting, continuous upward progression. So as you look at the pattern of PSAs over time, you can sometimes elucidate whether it's inflammatory or cancer on that basis. And for that reason, sometimes we'll check the PSA every month instead of every 3 months, which is the usual interval that we use in people that have normal declines.
So we have a daughter who's writing in on behalf of her father, and he had surgery about a month ago, and now the doctor is suggesting radiation. She says that when they had the pathology, it came back negative, and so she's wondering, does she commit to the radiation on behalf of her father? She's kind of taking care of him.
It's interesting. In professional circles, negative is a good thing, and maybe to a layperson, negative means that there is something bad, and the bad things could be a positive margin. That means that when they cut the gland out, they could tell they cut through cancer and left cancer behind. Or perhaps if they removed some lymph nodes, maybe there was some cancer in the lymph nodes. So those are negative things. But if you look at a negative pathology report in medical terminology, it means that there weren't any lymph nodes and there weren't any positive margins. But why would anyone be considering radiation at that? If everything is good. So apparently there's something that was left behind, and I can't imagine why the doctors would want to administer radiation for any other reason. The policy of giving radiation right after surgery is based in some clinical trials that showed better 10-year outcomes in people that had immediate radiation versus waited till a PSA rose above a certain threshold. There are some problems with some of those trials because they let the PSAs rise too high in some of those trials. So if people are watched closely, and assuming the PSA goes down to 0 after the operation, many doctors are starting to believe that if you jump in at the first sign of a PSA rise, that you're not going to lose much ground, and that way you won't end up having to radiate everybody you can just radiate the people that have a rising PSA. The issues of radiation right after surgery are not small. I mean, we know that there's a risk of incontinence and impotence from the surgery itself. And studies have shown that if you give radiation right after surgery, that you're going to increase the chances that impotence and incontinence are going to be more durable and less likely to recover normal function. My general bias is to postpone the radiation, see if the PSA becomes undetectable. That only takes a brief time right after the surgery. And if it is undetectable, then monitor closely, check PSAs frequently, and then if the PSA starts to creep up later, either do a PSMA PET scan, or if you use the traditional approach, start the radiation before the PSA rises up to 0.5. That's the cutoff point where long-term outcomes start to deteriorate if you allow the PSA to go too high.
Diving deeper here, when you say a short duration of time for the PSA to lower after surgery, what would that duration of time be?
Oh, within a month or two.
And as far as percentages of, salvage radiation, adding radiation after surgery, how much more of a risk is there for an incontinence and impotence?
It's going to depend on what the risks are for the individual going in. It's not like everyone that gets radiation will become impotent and incontinent. The best description I heard is that in men that have recovered very good continence after surgery, the radiation's not likely to make it worse. But in men that have only achieved partial recovery from incontinence, the radiation may freeze it in that status and disallow it from getting better in the future. People don't usually rush into radiation right after surgery. We don't believe that you have to do it right away. So if they do recommend radiation, usually they try and allow full recovery of sexual function and urinary function before the radiation is started, because the outcomes will be better in the long term that way.
So salvage being right after surgery, regular radiation with being without surgery, is the monitoring process the same for both?
Yeah, I mean, typically we do PSA testing every 3 months for a couple years after the treatment, every 6 months for another 2 or 3 years, and then annually after that. It seems to be a good policy. I mean, maybe you could say get away with every 6 month checkups for the first 5 years would probably be fine as well. Most people don't have such rapid doubling times that a 3 or 6 month delay in starting treatment is going to change the long-term outcome of the future. So yeah, usually every 3 months for the first couple of years.
So what should patients, if they're having salvage radiation versus regular radiation without surgery, would the PSA nadir be the same? Does it need to be like 0.1? And over what time frame?
Yes, it does. I mean, so patients that have had surgery and are undergoing radiation therapy for cure to try and keep the disease in control should, after the radiation therapy, have a PSA that drops down to less than 0.05 or undetectable levels. How long does it take PSAs to decline? Well, it depends on how high the PSA is when you start off, and then there's quite a bit of variability. We don't feel that it really matters how quickly the PSA declines, but if someone undergoes salvage radiation and they had a detectable PSA at the time of starting the radiation, the PSA should slowly decline down to less than 0.05 over time. It doesn't really matter how quickly, just so the PSA continues declining. When it stops going down, if the nadir, if it's above 0.1 or 0.2, then you have to deal with the possibility that there's still some cancer there. Sometimes the surgeons will leave a little bit of prostate behind, and that can cause a low stable PSA afterwards that you can detect. But if the PSA doesn't get down to low levels at some point, then there's almost always persistent cancer.
So what about in cases of younger men? We have somebody who's written in and they had a PSA of about 47, then they had surgery, it's down to 0.5, and now the doctor's telling them that they need external beam radiation and 6 months of hormone therapy as well. Since they're about 48 years old, they're I think the doctor's being very aggressive in his treatment strategically. Do you agree with this synopsis?
Well, I say what they're describing there would be a fairly traditional approach prior to the advent of these new PSMA PET scans. I can't imagine why they wouldn't want to do a PSMA PET scan. We can find prostate cancer down to PSAs as low as 0.2. This person has a PSA of 0.5 after surgery. I probably would have done the PSMA PET scan prior to surgery, and I probably wouldn't have recommended surgery for this patient. It is what it is, and at this point, yes, he's a young man. He's still got a detectable PSA, and we need to find out where the cancer is and certainly attack it aggressively with combination therapy, radiation when you find the cancer, hormone therapy, maybe not for 6 months, maybe for 12 or 18 months, and perhaps even a short course of taxotere.
On the terms of radiation, we've had another patient write in and they said that they had 28 rounds of radiation and now they're having hormone injections and the doctor is wanting them to get Lupron shots every 3 months for the next 2 years. They're wondering, do they continue just doing, PET scans every year, MRIs every year, PSA monitoring? What should that monitoring process be like if their PSA is below 0.1?
Yeah, I think the good news for prostate cancer patients, as opposed to other types of cancers, breast, colon, lung, cancers, there's PSA levels below 0.1 speak volumes about the fact that cancer is in remission. And you can trust that. PSA accuracy is sometimes denigrated because of it's not precise for screening for cancer. But once you've treated the prostate, we expect the PSA to remain low indefinitely unless there's a problem. We have talked in the past about bumps and whatnot and how to deal with that. If the PSA is remaining low, there's no need for scans. That's the beauty of PSA testing for monitoring after treatment. If the PSA is at 0.1 or less, close to or maybe undetectable in some assays, the idea of doing PET scans and CAT scans and whatnot is superfluous. You're not going to find anything. And that is the good news. It's pretty simple.
Thanks for watching. If you would like more information about prostate cancer, you can go ahead and subscribe to our YouTube channel. We come out with new prostate cancer videos every week. And go ahead and visit our website, PCRI.org. We have tons of information on prostate cancer that will help you.